Welcome everyone. My name is Kevin Thomas and I'm one of the managing members at Elevate Oral Care. We are honored to have Dr. Jacob Dent as our speaker today. His presentation is titled Oral Health Instructions for Special Needs Caregivers During COVID-19 and Beyond. I met Dr. Dent as he was preparing to deliver an AGD master course on preventive oral health for special needs patients. My youngest sister, Kay, passed 2 years ago from complications following dementia. She was a beautiful and full of life Down syndrome adult. Kay's lifelong care, including oral care, was a priority for our family. Understanding her challenges, I invited Dr. Dent to our 2020 national training meeting to educate our team so they could in turn encourage dental offices to open up care appointments to special needs patients. As you will find, Dr. Dent brings a very unique perspective to the care of special needs patients and to life in general, especially a successful and rewarding family and dental life. Dr. Dent is the owner of Sugarland Modern Dentistry and Orthodontics in Sugarland, Texas. He received his Doctor of Dental Surgery from Louisiana State University School of Dentistry and has been practicing for over 17 years. In 2006, Dr. Dent moved to Houston, Texas after Hurricane Rita destroyed his Louisiana office. That same year, his son was diagnosed with moderate autism at the age of 2. In 2015, Dr. Dent converted half of his practice to be sensory integrated and began focusing his practice on children and adults with physical and intellectual disabilities. Dr. Dent has published and spoken nationally, advocating for treatment of patients with special needs. Dr. Dent, welcome.
Thanks, Kevin. I appreciate it. And hello to everyone out there. This will be my first online CE class where, as I was telling everyone, I can't see you, you can see me. So this is a little weird, but we're gonna do our best to be informative today and also be as entertaining as possible while everybody's at home. So as we get started, first thing first, like I said, please know that this is a passion for me. As Kevin said, foremost, I am a dad of a special needs son who is now 16. So when everybody asks why I do this, that is why. So as we get started today, just kind of as a disclosure, to know I am the co-founder of the Brush and Bite Collection, and I have not been paid to promote any of the specific products that are in this lecture. All of the things that I will recommend to you are things that I actually just use in my own private practice. So again, there's me, there's all the accolades. Like I said, but the one that is most important to me is the last one of being a special needs parent. And as people ask, why do you do this? I had no intention of being a special needs dentist, but that is kind of the calling that the good Lord did for me, and that's where we are. So I always like to introduce you to the reasons why I do this. The two beautiful ladies there, my wife Jennifer and my daughter Jaden, and the mini me next to me is Ethan. That is my 16-year-old who is now a dental assistant in training. So that's why we look like twinsies here. So for today, one of the things that we're going to try to get everybody a little more comfortable with is just going through some of the most common forms of special needs and their associated health concerns that apply to us as dentists and hygienists. I'd also going to review with you some of the guides that I give to parents and caregivers on some of the best techniques and behavior management strategies that they can use at home, which will also carry over into your office, because that obviously is one of the biggest deterrents for everyone is behaviors. And then finally, we're just going to go through some of the products that they can get over the counter, as well as prescription products that I use to help with home care. So first and foremost, let's just go through and identify what special needs means. And that's just individuals who require assistance for disabilities that may be either medical, physical, mental, or psychological. So it's just not those that are intellectually disabled. It requires, a broader range of people that involve, like I said, anything from mental all the way just down to medical as well. So um, what is it that we are going to try to come through today and understand is the biggest challenge was as dental healthcare providers, we don't feel comfortable treating patients with special needs because a lot of us have never had the training or the experience in dental school. They just passed a law that said that dental school are starting to have to train on the patient care management for special needs patients. But I know for me personally, in my dental school education, I never got any training. Our special needs program was basically if you're in the GP program, then it refers to pedo or goes to GPR. But it wasn't something that I had hands-on experience with. And then for a parent or caregiver's point of view, they just don't know who to go to. So 9 times out of 10, they just avoid going. And the biggest fear that they have is just from the negative experience that either they've had in the past or they are anticipating they're going to have. But most of all, just being judged by the dental providers. A lot of times parents just they feel like they're not doing a good job. They know they're not doing a good job, and they really don't want to get berated for it. So we're gonna just watch a quick little video from a parent's perspective. And this is Ben's story.
Benjamin saw a dentist for the first time when he was around 2, and it ended up being an emergency visit because he had a seizure at our home. He fell, hit the wood floor, and his 2 front teeth had been pushed up into his gums. And so we took him to the dentist that we had been seeing as a family, and I could just tell by the dentist's body language and his assistant that they were nervous, and they weren't sure if it felt like they viewed him more of a liability than a patient. So it was, it was a little hurtful. After that, I just never contacted that dentist again. And looking for dentists that take our insurance and will also be willing to treat a child like Benjamin were few and far between.
It's the adult population that's really underserved. There's a huge gap between children and adult dentistry for special needs. And for those that are intellectually disabled or physically disabled, most dentists in this country just pass the buck to someone else because they don't feel like they have the training or the capability to see them. The biggest issue that dentists face is just lack of confidence in their own abilities. If every dentist was just willing to open their doors and see 1 or 2 people a week, you'd be amazed of how the access to care would just completely resolve itself. And all we would need to do is just kind of open our minds a little bit to that possibility.
All right. We're all good to go. Okay. So one of the things with that, obviously, with that parent interview was just kind of to show y'all from a parent's perspective that it is a challenge to find someone who's willing and understands just the struggles that the family goes through. So where we're going to go now is just to talk about the special needs, kind of the most common ones. Autism obviously will be our first. It is Autism Awareness Month, so that one obviously is near and dear to me. We also have Down syndrome, ADHD, CP, dementia and Alzheimer's, and then cancer. A lot of times cancer is not thought of as a special need, but we'll go through and help y'all see why that is definitely an unmet area that we can definitely get some some better understanding and help those patients with their concerns during their treatment. So autism spectrum disorder, it's a brain disorder that affects social interaction. And right now, this year, it came out to 1 in 54 kids are being diagnosed with autism spectrum disorder. I like to tell people, you know, they ask, well, where's your son on the spectrum? And, you know, I use the mild, moderate, and severe. So I would say he's somewhere between mild and moderate, depending on what day you ask me. There's a lot of difference in understanding the level, so to speak, of their disability. And each child is different. If you've gone around and had an opportunity to work with enough patients with autism, you realize that none of them are alike. Everybody is unique in their own individual disability, and they all have certain skills and they have certain areas that they need more work with. So here are the oral health concerns for our autism patient. Home care limitations obviously is the biggest struggle because of the fact that they are usually not willing or cooperative with their parents even to brush at home. So a lot of times because of that, it's very inefficient, not very effective, which leads to obviously more cavities, more gum issues. Xerostomia being part of the problem, that the dry mouth comes from the fact that a lot of these patients are on antipsychotics or antidepressants to help with their autism behaviors, so to speak, to help kind of regulate that. But that is a major cause of dry mouth. Self-injury can be an issue. Bruxism, definitely a concern. You'll hear a lot of times patients will walk in your door and you can hear them coming down the hall. They're grinding their teeth so hard. But a lot of their medicines that they're on, bruxism is a byproduct of that. Pouching of food, they have a lot of issues with just eating in general, textures, taste. A lot of them are on specific diets, very limited diets. So that can become a problem as well. Malocclusion, pica. We'll go through that in a minute. For those that don't know pica, that's putting non-food items in your mouth. Tongue thrusting and a hypergag reflex. Again, just the sensory issues. So self-injury. Now, if you see a child coming in with autism that looks like this, our first knee jerk is, obviously they're being abused. But a lot of times, one of the things that we notice is that when there is an undiagnosed dental pain, they will self-inflict, injury on themselves in that area as a way to communicate that there's something wrong, especially for our nonverbal patients. Pica. Now, while this little girl looks like she is having the time of her life eating all that paint, obviously pica can be problematic when it comes to putting non-food objects in their mouth. I have one patient in particular that eats Dollar General radios, just little plastic radios, chews them to shreds, and we've had to dig several plastic shards out of his teeth because of it. Pouching of food. This one obviously can become something more for us as dental professionals to look at if we see a lot of gum line decay. But my son in particular, he used to have this problem. It looked like he kept a doggy bag worth of food in his mouth after lunch and would just kind of eat on it as the day went by. So let's switch over to Down syndrome, known as trisomy 21. We know that there is the presence of all or part of the third copy of chromosome 21. And most commonly, this is very easy. We can see patients with Down syndrome just by their physical characteristics, obviously usually shorter in stature. Facial features are pretty obvious. But from the dental concerns, the things that a lot of dentists and hygienists don't know is, delayed tooth eruption is a big problem. They may not get their baby teeth until late. They may not get their permanent teeth until late. And a lot of times because of that, you see they kind of start getting shark rows. They'll get baby teeth still retained, permanent teeth come in. They'll come in different orders. but you may also notice that their permanent teeth are just permanently missing. Congenitally missing teeth is a big issue with Down syndrome. And their roots, you'll notice their roots of their permanent teeth are also much shorter. That is something to be aware of, especially when parents ask you about orthodontics. You need to make sure that your orthodontist that you're referring to or is in your office is well versed with Down syndrome, so they understand that they can't move teeth as quickly as they normally would. But for their orthodontic bites, you normally will see that they have a class 3 bite, and that's just mainly because of their small upper jaws. The upper jaw is usually constricted, and the normal thing that you'll see with a Down syndrome or typical is you'll notice a lot of them keep their tongue out. And so very rarely is it because of macroglossia. Their tongues are just not enlarged. It's because there's no space in their mouth because of the constricted arch at the top. So that can become, like I said, an issue, which leads to other things. Just from a cleaning standpoint, a lot of times we struggle with getting the tongue out the way so we can get to the teeth. Increased risk of periodontal disease because of their impaired immune system. And for those that don't know, atlantoaxial instability. So between C1 and C2 in their neck, the muscles and ligaments can become very weak. So you got to be very careful with them as far as hyperextending their necks back. This is one of the reasons why I try to keep patients with Down syndrome out of the OR, out of sedation situations, because if you have to intubate a patient with Down syndrome and you have to extend their neck, you risk a neck injury, you risk even paralysis. So be very careful with that. ADHD, I think this is probably one of the most common things that we see. This is a child that comes into your office that's just bouncing off the walls. Parents, say they can't get them to sit down, sit still. Boys are more likely to be diagnosed than girls. For us as caregivers and providers, the behavioral challenges are really the biggest issue. Just getting them to sit still, it's kind of like wrangling a box of kittens. Aggression, and excitability. They may come into your office, run around. It seems like they destroy every room in the office, take out every toy you may have, and you haven't even got them into a chair yet. Well, that's the same concerns that parents have as well. They're trying to get them to do brushing at home, and they're having to struggle with it. So that leads to their poor oral hygiene, and obviously the side effects of some of the medicines that they're taking for that. Some of those stimulants like Ritalin and Adderall do cause dry mouth, so they tend to be more of it at risk for caries. CP. I don't know if a lot of people see a lot of cerebral palsy patients in their practice, but one of the main concerns that we see is how do you get them into your chair? This particular picture is actually a family of 3. They're all siblings, but every one of them has some form of cerebral palsy. And so it is a struggle. A lot of times what I do and what I recommend, both to the parent and to the dentist that we train, is do your best to clean them in their own chair. A lot of times they're custom fitted for them. A lot of times they are more mechanical, so they can lean back just like our dental chairs. But it is a little bit easier to treat them in their chair versus trying to put them into our chair, get them out of their chair, and it doesn't necessarily fit or also kind of keep them in the same spot. Some of their oral health concerns that I'd like to go over with you is just obviously they are a higher caries risk because of their seizure medicines that tend to be a little more flavored, sugary flavored. Acid reflux is a big deal. Chewing and swallowing is an issue. You'll notice a lot of them come in, they're wearing bibs, they're drooling, and that's just part of the lack of muscle tone in their mouth to keep that mouth closed, so they just constantly drool. Alignment issues, gagging issues. Now, I always tell parents and dentists, you might have a patient that comes in and you're trying to clean them, and all of a sudden you barely get a toothbrush to their mouth and they're trying to gag and throw up on you. It's hard to determine it. You do it after a little while of getting to know the patient, but sometimes it's a true gagging issue. Sometimes it is a defense mechanism that they have That's just their way of saying, I don't want you in my mouth, so I'm going to try to do this to deter you from getting in there. So just kind of watch that. Be advised that it's not always a true gagging issue. It may just be a defense mechanism. Gingivitis, just like we said before, they'll have gingival overgrowth. So for some of their seizure medicines, pouching of foods like autism, patients do. Hygiene. None of my CP patients that I have brush independently. They'll go in, and if those that can, they do try, and they tend to, they're good at hacksaw brushing, so to speak, but they're not good at rotating. So we always ask parents or caregivers to help. G-tube fed in some cases. Now this is a big one because the question always comes up. Well, they don't eat anything or drink anything, so why should we brush their teeth? One of the main concerns with that is they're still going to build up tartar on their teeth. They're still going to build up plaque, which goes to the next one, which is they are a high risk for aspiration respiratory infection. Aspiration pneumonia for CP patients is one of the leading causes of death. And that's because they're sitting there, they're grinding their teeth, they've got all this buildup, they break that buildup off, and they aspirate it. Well, that gets in their lungs. Obviously, they get a bacterial infection, kills them. So maintain good hygiene for our CP patients, even those that are G-tube fed, is a major concern. Dementia and Alzheimer's. As our patient population continues to get older, these are patients that are going to continuously be seen in your practice. This particular picture, that's my grandfather who passed away of Alzheimer's. And it's a miserable disease, but it's one of those things where a lot of our grandparents or parents at this stage of our lives are noticing that whether it's assisted living or nursing homes, they're not getting the oral care that they need, mostly because they're at a level mentally that they're not willing to do it themselves. But also understand that there is no federal regulation or mandate that gives the nurses or caregivers the ability to brush if the patient is non-compliant. As opposed to, let's say they're sitting in their bed, they've got a dirty diaper, dirty pants, and they can do anything that they need to get them out of that, clean their sheets, and get them back into a healthy state. If they refuse to brush their teeth, they don't have to do anything. They can't force them. So this is where a lot of the elderly patients, their oral health goes down because there's really no ability for the caregivers to be able to work with them and help them do this. So their oral health concerns, obviously, number one is the poor oral health and home care because of their lack of cooperation. They are at increased risk for caries and gum disease, and their dry mouth, because of the same antipsychotics, again, that are used for autism, that's a byproduct. Back in the 70s, early 80s, anybody who went into a nursing home, they dentulated. They took all their teeth out for really this reason, because they knew they weren't going to be able to care for their teeth. So now, obviously, they're living longer, they're keeping their natural teeth longer, but this is still a major problem. And one of the reasons why we put it under our special needs list is that this is a group that it's a growing group, it's an unmet need, and it's something that you'll see in your practice, both dentists and hygienists. Cancer patients. Okay, so this is me 6 months ago. I had got diagnosed with stage 3 cancer last year. So as I told them, this pandemic we're all going through, it's not really that big of a deal because it's not cancer. So it's kind of the running joke I have with my staff. But understand that cancer patients are a medically compromised patient because the treatment that they go through just knocks their systems out. Now I'm in the Sugar Land area, so I have MD Anderson here, and that's where I went and got treated. But unfortunately, there are very few dental oncologists around. There's one in the Houston area that works with the cancer patients for as big as MD Anderson is. So we see a lot here in our practice, but it's understanding what their needs are. What is it that they're going to be dealing with? So some of their oral health concerns, chemo and radiation to treat the cancers, cause mouth ulcers. They're horrible. You'll see these really kind of the main concern in the beginning of treatment. Increased acid erosion from vomiting. I can tell you, first week that you get any type of chemotherapy, the smell of food makes you want to throw up. So obviously the constant vomiting will increase your acid erosion. Dry mouth is horrible. For some reason, it's kind of like the nail in the coffin. You know, you're miserable, you're vomiting, and your mouth feels like the desert. Your tongue is burning, peeling, or swelling. All your food tastes like metal, and really the decay and the infection increase just because your system is so depleted doing the chemo. It's like I said, I wouldn't wish it on my worst enemy, but anything that a cancer patient prior to treatment needs to get done should get done. So if someone comes in and says, hey, I just got diagnosed, I'm starting treatment, next week, cavities, perio, extractions, all of that should be done prior to starting, because once they start that treatment, they are not going to be in a position that they're going to want to do anything or can do anything. All right, so those are the most common special needs that we have that we will normally see in our home offices. And so now I'm going to transition a little bit and go to the hygiene for the caregivers. Now this is where it kind of gets a little lighter, because what we're going to go through is not only things that we as dental professionals can help guide our parents and caregivers, but also kind of create a teamwork here, because what they do at home is going to make so much more difference than the 2 to 4 times a year that you're going to see these patients for their regular routine cleaning. And if we can get home really good and that preventive nature really good, then it's going to make the visits to the office so much better and so much easier. So the first thing we'll do is we're going to go through the aided brushing techniques, then behavior management options, and then some of the products that we recommend. So just so you know, the way that I treat patients, special needs patients in my office, is I'll have the parent caregiver come to the practice, and it's just kind of a meet and greet. It's just, I just want to know, I tell parents, I have to treat their anxiety well before I treat the patient's anxiety. So it's just kind of a get to know, but also I'm trying to build a little rapport and understanding what their struggles are, because as a parent myself, I know what it's like going places and not having that time with a doctor or hygienist or whatever it may be, that I don't feel like I got enough time for them to understand where I'm coming from, which is unique to my child. So, but it also gives you an opportunity to, I guess, kind of level the playing field a little bit, because I'll give you a suggestion here, and I'll give you a scenario. A special needs child comes into your practice. You try to get the child to go sit in your chair, child's screaming, kicking, yelling, you can't do anything. It's a horrible experience. And the parent looks at you like, you must be a horrible dentist or a hygienist. So I kind of take that opportunity and I say, okay, let me switch gears. I let the parent actually be the dentist or hygienist, so to speak, for the first visit. I want to see what it looks like at home, okay? And so that's what I do. I always tell the parent, look, tell me what it's like at home. So this is what I usually get, probably 9 times out of 10, doc, it's wonderful. Susie is just an angel. She does a great job. She brushes independently. I really just have to go behind her. It's not a struggle at all. Wonderful. And there are times when that's true. Not always, but sometimes it's true. So I say, Mom, Dad, show me what it looks like at home. And this is what it comes out to be in my office. It really turns into some form of a WWE wrestling match. And these are sometimes the same families that will tell you, I'm not a big fan of stabilization. And here will be someone that is 3 times the size of the child, laying on top of them, pinning them against a counter, or doing some other form of physical restraint, and then wedging a toothbrush as fast as they can into their mouth. So again, there's an opportunity for us to learn a little bit. Now, we all have, as doctors or hygienists, what is the next question we're going to ask? How's flossing going? Are you flossing? Now, our neurotypical patients are going to tell us the same thing. Not every day. Special needs patients and families do a little bit better job. They're just very honest. They say, nope, hadn't tried, ain't going to, not going to do it. And really, this is kind of what they look like. They're like, yeah, I like you, but you're crazy. If you think that's going to happen, that's not even part of our regular routine. So then we go to the next level, which is, where are you brushing? Is it sitting or standing in the bathroom? Are they doing it in the tub or the shower, or even laying down? And I tell parents, I don't care where you do it. I've got it set up in my office where you can short of the shower. We don't have a shower here, but you can simulate and repeat everything that you're doing at home here, so we can kind of build upon that. But any of these options work for me. But one of the things that I try to do is I try to tell the parent, okay, what we can do right now is work on the things that aren't necessarily the proper way of brushing or flossing. So I'm going to go through a few different scenarios of the typical at-home parent brushing techniques that we see. This is the first one. This is what I like to call the headlock or the football hold. So when I ask a parent to demonstrate, what they'll do is very similar to what I'm doing with Ethan right here. They put them in a firm headlock, rip their mouth open, and try to shove that toothbrush as fast as they can in there, probably not getting a very efficient job done. But that may be a good 20, 30 seconds done before they escape the headlock. I also like it usually comes from the moms, but it's what I call the hip check technique. So they'll do the headlock, and then they'll kick their right or their left hip out, pin them against the wall, and then that's where the brushing starts to happen. So that one, again, is not a very efficient technique. The next one is I call the chicken pecking. So you'll see a parent, they'll hold the face like this, and they'll start pecking at them. There'll also be the ones that they say, well, I can't get the back, or I can't get their cheeks, or you realize that all a patient has to do, or all the kid has to do, is take one step back or just move to the side, and they're away from you. You have no ability to maintain that position. And there's absolutely no way to get the cheeks out of the way here. Because if you're just trying to support the jaw, how are you going to pull the cheeks side to side or get the lift down? So we avoid that one. Now, this is the position that I always try to maintain with a parent to demonstrate to them, which is exactly the position that the dentist or the hygienist is going to be in. So tip 2, you want to have them sitting, and you want to try to be taller than them. Now, if your kid is 3 foot, you don't have to have them sit down, but it does give you, as you can see, the ability to retract the cheek, or just have the person kick their head back so you can see everything. The lack of vision is the biggest concern that most parents have. Excuse me. Now, I always get asked, and I'm always told, I can't get their lower anterior teeth to be brushed, because I'll try to demonstrate it on the video, but they get this like nice tight lip, and that is strong. That lower lip is just, you can't get it in there. So again, if you can take, and I always tell them, point your finger away from the teeth so you keep your finger. Fish hook in the cheek, and then roll that finger down inside the gums like you can see, and that will expose that lower lip so you can get those teeth cleaned up. All right, now, so how do we tell them how to brush? In the world of special needs and autism, we utilize ABA therapy a ton. And so for the years of therapy that we did personally, I came up with what's called the rule of 5. And the rule of 5 is very simple. It's short intermittent stages of brushing, followed by some form of positive reinforcement, and then continuously done. So for example, I get the kid to take a toothbrush. 1, 2, 3, 4, 5. Great, high five. Switch. 1, 2, 3, 4, 5. Anything that they will use as positive reinforcement, that could be high fives, verbal praise, tickles, whatever it may be. But you're 5, 5, 5, 5. You can do 5 in the front. And so when you really think about it, doing one cycle of this is about 30 seconds. Excuse me. So if you're looking at this from a parent's perspective, I'll say, Mom, show me how you're brushing. And they like, okay, well, we sing the Barney 1, 2, 3 brush your teeth song. Well, that's great. That may be a 2-minute song. But I also tell them, what happens if you want to go on date night? Over and she don't know the Barney 1, 2, 3 brush your teeth song. Toothbrush is out the window, but everybody can count to 5. So whether that's at home, your therapist, your teacher, doctor, everybody can do that 5. Ethan today, I give him a toothbrush, 1, 2, 3, 4, 5. 1, 2. He knows. And if he does it too quick, do it again. I still go behind him and help him, but we're trying to create an independent person, because while they're kids and in our home, super easy to manage. We're not always going to be here as parents, and so we're trying to create a lifelong independent self-help skill here, and this is a good way to do it. All right, so the 2-minute rule, just for everybody who knows this. I'm very honest about this. I did not get this till pretty recently. So the reason why we recommend 2 minutes that's not why the toothbrush is, because the electric toothbrushes are set to that. It's because over-the-counter toothpaste requires 2 minutes of active manipulation for the fluoride that's in those toothpaste to actually get into your teeth. So if you're brushing, I'm done. All you're using is just the abrasive. You're not getting any benefit of the fluoride, which makes you more prone to the cavities. All right. Excuse me. So the Dental Ninja and the Dental Clan, pretty self-explanatory on what our biggest behavior management challenges can be. This is home and the dental office. So everybody on, I know there's a lot of dentists on, there's also a lot of therapists and parents on here. So this kind of speaks to everybody. So the Dental Ninja, what does that mean? That's the patient that you go, they sit down, you bring a handpiece, a mirror, or whatever, and you get this. It looks like a mixed martial arts scenario happening. For the Dental Clam, those are the ones that's just lockjaw. They're not letting you in. You can't get in there. You can't even seem to pry their mouth open. So I'm going to give you a few little extra hints on how to make that happen. Before we start, one of the things to understand is why the reasons for the negative behavior. And this is a vicious cycle. So the 2 most common reasons for negative behavior with special needs patients: constipation and undiagnosed dental pain. So a patient comes in, very negative behavior, or maybe the behavior has gotten worse. And you notice for the parents and caregivers, one of the byproducts of the medicines that you give, all the antipsychotics, antidepressants, is constipation. So there are times where kids may go a week without going to the bathroom. That causes negative behavior. Also, like we said with the self-injury and autism, a lot of the negative behaviors and the hitting comes from tooth pain because, well, they're having negative behavior. They won't let you in their mouth. They're a ninja. They're a clam. They're not letting you in. So things get missed. And then that's when infections grew, and that causes more behavior. But what the cycle starts to happen is they're not understanding what's causing it. So what do? They give them more medicine to make the behavior go away, which causes more constipation, which doesn't fix any dental concerns. And eventually you end up with a patient who's almost like a zombie. Or I'll have people come in and like, we gave them extra of their medicine, so hoping that it would calm them down. I hate that. I'd much rather fight, a battle of behavior than to just be trying to work on someone who's a zombie. So some of the 2 biggest categories that we have with behavior management, and this is both at home and in the office, are going to be desensitization and stabilization. Now, when a patient and a family comes into my office, I give them a special needs checklist, so to speak, a kind of a get to know. Instead of a health history, it's I want to know kind of about your kid specifically. And so part of that, the last question is, what would you prefer? Desensitization, stabilization, or sedation? Now, in my practice, I try to avoid sedation at all costs for different reasons, but mostly because there's no benefit to teach a patient how to go to the dentist and do it well if all you do is knock them out every time they go to the dentist. This is one of the projects in the research programs that I'm working on right now with Baylor Medical and UT Dental is adults that have only been sedated for their entire lives for dental work. How can we desensitize them to at least be able to go in and do, say, a cleaning? And the results are being, amazing right now. So desensitization. There's really three options that we all have. The brush and bite starter kit, which again it's a kit that I invented. So full disclosure there, I invented it, but I needed a way to manage some of the sensory issues that kids on the spectrum deal with at home. It translates into the dental office, and it was just getting to a point where they would come in twice a year, and it was horrible. We weren't getting anywhere. It was like, I couldn't get x-rays. I couldn't even get a good cleaning done. And so where we have to look at it is if I can utilize the parents or caregivers as well as therapists, behavioral therapists, and they're using the same tools and kits that we have here to go through and desensitize them to that process, it makes the world of difference. So the dentist or the hygienist is not feeling like you're trying to be a behavioral therapist and the dental provider. So ABA therapy is another one. That, like I said, we were in ABA therapy for years with my son, and if you're seeing a family with autism, 9 times out of 10 they're going to be in some form of ABA therapy. And then also for the dentist, create a sensory room or social stories. Social stories is basically just a picture diagram of the steps of what you're going to be doing. And then going down to stabilization, I ask when we talk about stabilization, everybody's on different ends of the spectrum, but most people's thought is it's a white padded room, you're strapping someone to a table, and it's going to cause all types of neurological stress and trauma, and we're just going to have to go through therapy for years after that. That's not the case. Stabilization is actually probably for most, the unknown is it's actually a soother for a lot of patients. My son will go get a stabilization board, pull it out like it's a sleeping bag, lay in it and watch TV. There's no negative connotation to that. So let's go through a few of these things so we can kind of explain that, and I'll demonstrate some of those. So this is the brush and bite starter kit. You can order that online, but what it has inside of it are the basics: mask, glove, mirror, patient bib, small suction, flosser, prophy paste sample, prophy cup sample, and a fluoride tray. So, but if you look at this, the understanding is obviously we do a really poor job as dentists, because for our normal, we put on gloves, we put on a mask, we come from behind the patient, we put a bright shiny spotlight in your eye, and we lean over you. And that's not a good experience for really anybody, especially a special needs patient. For the patient bib, like my son does not like tags in his shirt. It's a sensory issue. You could do everything well and just put a bib on them and they will lose their mind. You might as well just shut it down and try again another day. For our therapist to work on with the small suction is just to learn how to put your lips around it. Flossers, obviously self-explanatory. Mirrors for the parent and caregiver to practice looking. Prophy paste because of the texture. A lot of patients are texture sensitive, not just flavor sensitive, but texture sensitive. So they can practice with that to get used to our prophy paste. The prophy cup is just because a lot of them, man, they're great with their toothbrush, but you may not have the SpongeBob spin brush in your office, and your spin brush looks like this. and it turns into another meltdown. And finally, the fluoride tray. I put a fluoride tray in there not because we do foam fluoride, but because you can take a fluoride tray, cut that little piece in half, put it in the mouth, have them bite down, count to 5. Everything's a rule of 5 in my office. Count to 5, and that teaches them how to hold an X-ray film, so you can actually practice getting X-rays. So ABA therapy. We'll move on to this. ABA therapy stands for Applied Behavioral Analysis. It's basically just a repetitive set of learning that takes one task, breaks it up into specific parts, and then builds upon it slowly and steadily. So it uses positive reinforcements to get the desired behaviors. But here's a picture, and I'll kind of walk through this. Obviously, this is in the room that I'm in right now. I'm sitting on the floor. The little boy is the patient. The gentleman sitting in front of him is his therapist. And his therapist actually has a camera and is taking pictures of him doing the work with me. So they can take that, go back home, and go through it. You know, it's part of their social story. And then the little girl in the back is the sister. We always ask siblings to come with them if they have them. And that's basically more of a kind of a mimicking or demonstration person that we can use as a modeling technique. So there's different various ways that you can do this, but like I said, I bring a team together. I realize there's nothing special about what I do. I just know enough as a parent of a special needs child what not to do and what to expect as a result of it. So this is what my social story that I send out to the families before they come into the office has. For those that are on the call and want to know more about this, I actually have this in a PowerPoint. You're more than welcome to send me a message and I can send it to you and just change the pictures out. You're more than welcome to it. So I'll just go through it. So obviously that just introduces you as the dentist. What happens on our visit? We wait our turn. We play with toys. Most of my patients make it through this step. The next one is we take pictures. We sit in a big chair. We put on some sunglasses. I put on my mask and gloves. Dr. Dent looks at my teeth. We brush our teeth. I get a toy and I get to go home. I mean, that is just about as easy as it comes. It's just, 10 steps or less. Some of these social stories can be very few steps. Some can be 30, 40 steps. It really just depends. So, I always try to explain, that's why the individuality and the specific child or adult needs to be kind of focused on as an individual, because what it may take my kid to do in 10 steps may take another kid, 20 steps to do, but the end result's still the same. So what about setting up your office to be a little more friendly? Because trust me, 4 beige walls and a dental chair is not a really good experience. Not a good experience for most neurotypical people. But this right here, what you're seeing, is my sensory room. So I took my old waiting room, like Kevin said in the beginning, I had my practice here in Sugar Land. I took half of it and created a sensory integrated practice. So this is where I meet and greet families for our first visit. So it's got books, games, kind of like Toys R Us threw up in here. We've got the iPad stations. I've got a futon. I've got a 6-foot beanbag. And always the question that someone's going to have on here is, why is there a shovel on the wall? It's not it's not the final behavior modifier in the room. It is just an award that I've received. But it does get asked every time I make this lecture. So we're not beating any children or adults with a shovel. This is the room that I'm currently in. So this is an open bay. I have 3 different types of chair setups in here. First is the ortho bench. And why did I decide to put an ortho bench? Well, that's because a lot of patients, especially with special needs, they have a instability. And so if you try to lean them back, they freak out. So I wanted something that was already laid down and flat so they could lay down themselves to avoid that trigger, so to speak. In the middle is actually a mobile dental cart. so I can move it anywhere. If a patient doesn't want to sit in a chair or lay down, we'll sit on the floor. We'll pull up a bench. What you're seeing in front of there is actually a blow-up canoe that I got from an autism website. Kids enjoy playing in it. And, if they're not sitting in a chair, I can drag their little butts anywhere in the room and we'll just brush their teeth in that. And obviously a regular dental chair. Now, for those patients, again, it's kind of like, well, I see something else in the room. There's a trampoline. Yes, I do have a trampoline in my office because if I have a patient that comes in and is just bouncing off the walls, won't sit down, I send them to go bounce it out a little bit. Good physical exertion is a good way to get them to kind of calm down, so you can at least attempt to get something done in your appointment time. And lastly, this is another example of one of my rooms, and this is a great way to practice at home, because we get a lot of questions from parents or therapists who may not have a dental chair, obviously, and they're struggling with getting their child to sit in a dental chair. I have one adult in particular that, as long as I've worked with her, I've never gotten her to sit in a dental chair. And we're talking about years. So what we did is I actually got, her parents said that she likes to sit by the pool in one of those little deck chairs. So guess what? They bring the deck chair into my office, we put it right in the room, and she sits in that just like it was nothing, and that's where I clean her teeth. So you'll notice in here, I have a beanbag. So a beanbag is a wonderful way to transfer from home to the dental office. So parents grab a beanbag or therapists grab a beanbag, have the child sit in the beanbag while you're brushing their teeth. It teaches them that they have to sit when someone else brushes. And then I take the beanbag, I move the beanbag to the dental chair, and then I take the beanbag out of the chair, and now they're in my chair. And that's just the step-by-step. It doesn't happen all in one visit, but it's a progression. What you can't see in here is I actually have an iPad station with games that is right there next to it, right by that plug in the beanbag. So the kids go in there, sit in the beanbag to play the games. Well, it's a distraction. So they have no problem, getting their teeth brushed as long as they can play their game. So again, it's just little ways to desensitize them to the dental procedures that we do. So let's get into stabilization. Now, again, combating the myths about stabilization, I'm going to show you some of the things that I teach parents and caregivers to do at home. So floor stabilization is very simple, and like I said, this is what combats the ninja. So the picture here to the left is Ethan and I demonstrating this. So what you do, put a pillow on the floor, put the kid in between your legs, and you put their arms underneath your thighs. So they can still move, their hands just can't reach their face, okay? And then I'm using one of the brush and bite handles with the 3-sided head, and it also has a bite block to help brush. To the right is actually, this is a practice in Georgia that I was asked to come do some training at, and the lady in the red is the mom, and the lady to my left is the other dentist. And so their concern was the little boy here was just petrified of getting into the practice. And literally, I mean, it was like a cat being thrown into water, wouldn't even come in the door. So we made it to their waiting room, and I was showing them the floor stabilization on how to do this because mom couldn't do it at home. It kind of looked like that wrestling match. So they did this, and then this is 2 years ago. Today, I still track them, and the dentist is posting pictures of the same little boy now laying in her chair, doing all the routine dental visits because we started small. We started with something like this, okay? The next one is pillowcase stabilization. Now, I have a parent that says, we don't want to stabilize. And there is, you've got a ninja, that is kicking, punching, screaming, doing all nonsense, but parents don't want to stabilize. And I can respect that. So I'll say, well, how do you feel about using a pillowcase? I can manage a pillowcase. So what you do, and I will, full honesty here, I didn't come up with this. When Ethan was 3 years old, he fell on the stairs and busted his head open. So we had to take him to the hospital and get stitches. Well, even then, he was a good, ninja in the making himself. So I told him, I said, you're going to have to knock him out. He's just not going to do this on his own. So the little nurse said, don't worry about it. Well, he'll be fine. And she took a little pillowcase, put his arms in it. And what you do is you put their arms behind him, put the pillowcase up, and you just suck it up to their shoulders and sit them down like I'm doing. They can't get their arms out. Their arms don't bend up like that, so they can't get out. So again, that limits their arm movement to a point where you can just manage their head. Dentists and hygienists, we can only manage one body part at a time, and so this is a good way of doing it. Now, if it's a smaller child, let's say, 2, 3 years old, moms, dads at home, you can do this, even just do what you did when they gave you the child when you went home, swallow them. Use the bed sheet to just swaddle them. It's comforting. It's nothing that's, it's not going to cause any traumas, but it keeps their body stable so you can do what you need to do. Okay. So that's also a quick, easy, and cheap version of stabilization at home. And then arm and leg stabilizers. Now, these actually come from Specialized Care Company. I love these. It's nothing more than a piece of material in Velcro. But what it does, I call it my robot arms. It keeps them from being able to bend their arms. So they kind of can only do this, but they can never come back to their face, which is very helpful. For their legs, you'd be surprised at how flexible some of these patients are. And if you don't have their leg, if they are kickers, and you don't have their leg tail up, he could kick me straight in my head when I bend down to look in his mouth. So that's why I demonstrated what the leg stabilizers were. These are also good parents for the side. These are great for any type of other at-home things that we struggle with. So for the dentist and hygienist on the call, this may not so much apply, but when you look at a patient with special needs, look at their fingernails. If you see that their fingernails are overgrown, toenails are overgrown, haircut looks kind of shoddy, that's probably a struggle that they're facing. I've got it set up. I've done haircuts in my office. I've done, we've clipped fingernails, because if you can stabilize that, you can help. It really does help the patient. So those are great for many other things other than just dentistry. But it is a very easy form of passive stabilization. So when we talk about active and passive stabilization is someone physically holding you down, which is pretty much what every parent does in some form. Passive stabilization is a stabilizing board, arm and leg stabilizers, a pillowcase, anything that's not physically someone else holding them down. Mouth props, for hygienists on the call, doctors on the call, the mouth props are also from Specialized Care Company. This is what I use in my practice. It has an external handle, so your hands are outside the mouth as opposed to just using the bite block, which they'll spit out in a heartbeat. But also you can run your small suction through the hole in the bite block. So it's a way that you can kind of grow that third arm without having 3 arms to be able to support, suction, and do your work at the same time. So those are a great opportunity. For the at-home, like I said, the brush and bite handle is actually, I invented that because I had so many families that were saying, we can brush, but they're biting down, we can't keep their mouth open. And obviously they don't have dental blocks and props at their house. So I just built in a dental prop in the back of a toothbrush. So you can use one toothbrush to brush, the other one to prop open. And like I said, whether that's a regular toothbrush, electric toothbrush, makes me no difference, but it's the handle that really makes the access a little bit easier. That's what's great for your clams, So I'll give you a pearl. One of the ways, if you get a clam and I'm not opening, you can always get your finger in the side of the mouth. The lips, you can't purse them tight enough where you can't get your finger in there. Now, in the back of the jaw, where the jaw hinge is, for our parents at home, when they open up, right in the back there, it's a little pressure point. Also, your frenums, top and bottom, it's a little skin tag that holds your lip and your gums together. That is also a pressure point. So if you get your finger in there and you can press down on that, boop, that mouth will open up, okay? And that's how you can get your mouth prop in there. All right. So finally, let's go through some of the things that I use here in the office. The products, like I said, what you see is just a picture of the stand that's sitting in my sensory room over there. So I'm just going to go through some of these to let you know what I use, and then kind of give you the recommendations of what you can and can't use, and some of the questions that will come up with it. Okay. So toothbrushes, I tell parents, I don't care. I don't have stock in any toothbrush, manual or electric, but for the dental professionals, we always say, electric is better, but understand that a lot of special needs patients have sensory issues, so the vibration may be a challenge. So that's something to get the therapist to help work with, to kind of desensitize to. As far as what I recommend myself, I recommend these two brushes. Obviously, the brush and bite handle, which it has the capability for the top for a three-sided head to fit on, which the three-sided head comes from triple bristle, which they make both a kid's and an adult's three-sided toothbrush. So that's what's in my office. That's what I recommend. Again, why? Because a lot of patients are great at hacksaw, but they do not rotate. So they miss all their gum lines, and that's where a lot of the perio conditions come through. I got this from the occupational therapist that worked with my son, and they said, if you can't tie your own shoes, you do not have the dexterity to brush properly. So parents and caregivers will always need to help brush and floss until they can do that. Now, let's say your kid can tie their own shoes and still does a poor job of brushing. That's more of they have the ability, they may not have the desire, but they have the ability. So if you're looking at this as a parent or caregiver, use the shoe tying thing as a good kind of, I guess, a litmus test to see what you need to do. My son is 16 years old. He still doesn't tie his shoes. And a lot of times, parents, we buy slip-ons or Velcro because it's easier, but he doesn't tie his shoes. So he brushes independently. And then I still go back, even at this age, and do it myself to help him out to make sure it's done properly. So that's a good rule for everybody to understand. Toothpaste. Okay, so really, I don't really care what type you get. These are just two examples of it, but really comes down to fluoride or fluoride free. Okay, so a lot of families are going to come in and say, fluoride is poison. I read it on the internet. It's a neurotoxin, which is true. It is a neurotoxin in certain forms. Or one of their concerns is my kid doesn't spit, so they're just swallowing it. And I don't want it to cause issues in their system, because being a neurotoxin, as families go in the autism world, we're trying to basically kind of detox our kids to get them, as well as they can, mentally. So I have no dog in this fight, and I will tell hygienists and doctors, this is not a mountain to die on. It's not a fight that you really want to get into with a special needs parent, but it doesn't mean that you can't give them advice, okay? So I always tell them, Ethan has always used a fluoride toothpaste. I'll show you my recommendation of how to use it, but he didn't spit till he was 10, He doesn't have a third eye or, an arm growing out of a weird place. It didn't cause any neurological damage, but he also hasn't had a cavity in his entire life. So that's also the benefit of it. For a prescription toothpaste, these Floramax 5000, that comes in basically an adult and a kid flavor. This is what my entire house uses. I use it. I use the bubble gum because that's what Ethan uses. So we brush together at night, and it's a good daily. It's kind of like taking a daily vitamin for me. Even though he has special needs, I have a neurotypical daughter. She uses it. My wife uses it. So it's good for everybody. And like I said, this is the when someone leaves, they get a prescription toothpaste, a new toothbrush, and I'll see you in 3 to 6 months. Now, the proper amount of toothpaste for everyone, like I said, we all know this. All the commercials show you, hey, just squirt it all on top. A pea size is what's recommended, but where do we normally see what kids do? Man, it's a good bubblegum flavor. I enjoy that. I take the toothbrush, put it to my mouth. Before I get it to my teeth, I suck all the toothpaste off. Okay, so now we got to add more toothpaste, and it's a battle that we fight. So for the parents and caregivers, and especially hygienists and doctors on the call, I recommend just tell the parent to impregnate the bristles with the toothpaste. So I just put the little drop of toothpaste on the counter. I mash it into the bristles, then give it to my kid. They can't get it out. They can't suck it all out. So obviously it spreads a little bit easier. Flossing, if you can use regular floss, great. I'm a big fan of it. If you're going to use a floss aid, I recommend something like that Listerine has out there with a handle, because it's really hard to lose fingers or get bit. I think we've all had that happen at least once in our careers. It's not fun, and there's a lot of parents out there that have also been bit, and so they're trying to find an easier way to floss. This is a good way to do it. Use that mouth prop or the brush and bite handle, prop one side open, floss, and then switch. Makes it a lot easier if you're doing it just with one person. Mouthwash, obviously this is another issue when it comes to kids that don't spit. So for those that do, over the counter, I recommend the Listerine just because it's antibacterial. I recommend the zero alcohol so it doesn't burn. Act, obviously, just because all the flavoring that it has, different options, that can sometimes be an issue. But what do you do if a patient doesn't spit? You don't want to just give them a big thing of Listerine and have them swallow it. So what I recommend is after brushing, take that Listerine, put it on a cotton ball or a Q-tip, dip it in there and just paint it on the teeth. That can also get you the same results that we're looking for. Anything that we can do, like I said, you just got to think outside the box a little bit with some of these. Now, for the prescription mouthwashes and things that we use in the office, I think we all use chlorhexidine for our perio patients. And probably I would say most of my special needs patients, at least 80%, and that's being generous. At least 80% of my special needs patients have some form of periodontal disease. So chlorhexidine is kind of our standard, but I see some doctors and hygienists, they're like, here's a bottle of chlorhexidine, just use it every day. It's a 2-week prescription. And then a lot of them say, okay, use this for 2 weeks. Well, what do you do for the other 2.5 months? Oh, I've heard everything from salt water, Listerine, whatnot. If it's an active periodontal disease, I do 2 weeks of chlorhexidine, and then every day after that, we use the Stance fluoride rinse. And that, again, it's antimicrobial, it helps keep that plaque down. It helps give them a little daily fluoride, but it's something more than just, hey, here's 2 weeks, and I'll see you in 3 months. You got to bridge the gap a little bit better. So again, those are the products that I recommend that I use in my own office. Lastly, dry mouth. As we saw through all of the special needs, every person in those categories has dry mouth, mostly because of just the medicines that induce it. So when I was going through my cancer treatment, I tried all the over-the-counter remedies, Biotine, artificial. I mean, I ordered everything I could because it's horrible. All day spray that comes in a little squirt bottle like this, I found to be the best option for me. It also has xylitol, so it's helps with cavities during that time. When I went through, I got samples of this, and I just dropped it off at MD Anderson, and you'd be amazed of how many of the nurses there were just so thankful that they had something to give their patients other than ice chips, and because that's what they gave me. So it was a big help for those patients. So again, overall, special needs, you're going to see them in your practice. What we can do as healthcare providers is build your team. Get your parents involved, get your therapists involved, or teachers. You know, a lot of schools have therapy or special needs teachers at school. Get them involved, educate them. Just create that consistency with everybody. So, final thoughts before we close today. It takes time. You're not gonna have a special needs patient come in your office day one and everything runs smoothly. I've been doing this for a very long time now, and this is all I do is see special needs patients. And there may be a unicorn in there, but very rarely is it just a smooth sailing. So understand not every visit is going to go well. It's going to take time, but understand that each patient's going to take a little individuality, and you're going to have to plan their care based off of their needs. Secondly, from scheduling, this is another thing for everybody. You know, whether you're the parent caregiver or the dentist and hygienist, schedule them when they're at their best. So here's an example. If I give Ethan his medicine at 8 o'clock to go to school, I'm not scheduling his dental visit at 3 o'clock when his medicine's worn off and he just spent a day getting, mentally exhausted at school. It's going to go bad, okay? But, if you also know you've got say an adult patient that usually doesn't wake up till 10 o'clock, don't schedule 8 o'clock and expect them to be, happy about being there. So schedule when they're at their best, but also doctors and hygienists, look at your schedule and try not to book them when you've got 3 or 4 other patients going at the same time. You're going to have to take some time to devote to that patient. And that's just going to be, the way of the world when it comes to special needs. But I promise you, I will bet everything I own on this. I don't advertise anything in my practice. I don't advertise that we do special needs. And I have more patients than we can see, because families are coming in knowing that we're going to do this service for their special needs family member. That same family becomes members of our practice. For my other associates that are here, they see them, and it becomes a place where everybody can come. So if you want to grow your practice, this is a great way to start. And then finally, consistency is key. Like I said, make sure everything that you're doing at the dental office is replicated at home or at school or by your therapist. All right. And in closing, y'all, we're going to play one more video for you.
Unconditional, unconditionally, I will love you unconditionally. There is no fear now. Let go and just be free. I will love you unconditionally. Come just as you are to me. Don't need apologies. Know that you are all worthy. I'll take your bad days with your good. Walk through the storm, I would. I do it all because I love you. Unconditionally.
Thank y'all all so much for your time this morning. Thank you for sharing my passion for the special needs patients. This is my contact information. If anyone would like to reach out to me, more than happy to answer any questions you have, or like I said, if you want to know a little more, like Kevin said, normally I try to take care of some of the special needs lectures for the AED, for those mastery level classes. So if you really want to dive in a little deeper, please let me know. We'll be happy to do that. But we'll take some questions, and everybody have a great day, and stay safe out there.
Thank you very much, Dr. Dent, for a great presentation. This is Steve Pardue, one of the managing members at Elevate Oral Care, and I'll walk through some of the questions here. We did receive several questions as we went through the presentation. I think many of them got answered as you went through the presentation, so I'll do my best to filter through the remaining questions here. First question is regarding some CP patients present with extensive calculus, no caries, no significant inflammation or bleeding, and in the absence of those, how do you determine the need for professional cleanings, especially if it's going to require general anesthesia? Are there guidelines? Are there decision trees that can be used, or is it professional judgment?
That's going to be professional judgment all the way. And so one of the things that I do is okay, so this kind of goes against a lot of hygiene dentists. What we were taught is, man, we got to get it all off. We got to get taken care of at that one appointment. I honestly, I do a lot of incremental. I see patients every 3 months. There is no way that you are going to remove all of the tartar and calculus on some of these patients' teeth in one visit. And so, but if I do it methodically, a little bit at a time, it helps desensitize that patient so you can avoid going to the OR, as well as, like I said, eventually get them back to a state of health. But like I said, I didn't want to get on my soapbox about sedation, but understand this, and I'll say this real quick, is anytime that you go into an OR with a special needs patient, with a neurotypical patient, and they get a full conscious, deep conscious sedation, it actually kills brain cells. So you are seeing patients that are regressing mentally by doing that. So that's why, like I said, we're doing a lot of things working on desensitization right now, but at all costs, in my practice, I try very hard to avoid sedation.
Okay, thank you very much for that. This is kind of a practice and a policy question. This particular dentist has been in practice for some time, also is now working on dental policy for their state's Medicaid program, and her struggle is, as a clinician and a bureaucrat, how do we get dentists to care about special care patients? How do we get information to the correct people?
Right. So the question should be, what deters dentists from doing this? And the answer is time and money. It takes a lot longer to work on a special needs patient, and you do not get paid for the extra time if you're a general practitioner. So, and as long as I've been doing this, I get asked that question all the time. Okay, so how do we move the needle? How do we either make it to where we get paid more for the service, or it doesn't cost us as much time? Well, I'm not a bureaucrat. I'm not gonna, it's probably not gonna change in my lifetime. But one of the things, and the way that I combat it, is I use the people that are getting paid to help with the behaviors, which is the behavioral therapist. So that's why we created the kit. I let them work on it, so when they do come to my office, the appointment times are much shorter because I'm not having to manage as much behavior. And like I said, I see more frequent visits. The average, like I said, the average in my office is 90 days between cleanings, just to make sure that we're staying on top of any health concerns.
Okay, very good. Appreciate that. There were several questions about special needs dentistry in the new world of COVID that we're going to be coming back to here. Increased risks for aerosols and needs for oral hygiene. What are some of your plans to adapt to maintain some of these cleanings that are needed that do have increased aerosol concerns?
Right. So depending on the state that you're in, for hygienists, you're advised not to use your Cavitron. Dentist, obviously, hand pieces. I do all my own cleanings for the special needs patients in my office. So, that's a concern for me as well. But, I don't think there's no difference in what we've been doing and what we will continue to do. I think the biggest challenge for all of us right now, whether it's a special need or a neurotypical patient, is, are we going to have enough PPE out there to, utilize so we're protected until we see a curve? But I'm not, honestly, I haven't changed anything the way I practice. The PPE that I use from before this pandemic started to now. Like I said, I think that's each individual practitioner's point of view, but our biggest struggle is going to be finding the PPE out there that is the CDC and our local boards are recommending that we use.
Okay, thank you. And to continue on that question, with the new COVID restrictions, you have lots of open bays, toys, and items that are used for distraction. Do you have any special infection or cleaning controls in place for those? And are there any concerns about that, having the open bays with HIPAA?
Yeah, so in my office, in my open bay here, I still only see one patient at a time. Even though there's 3 chairs in here, there's never more than one. I take it back. There may be a couple of patients, but they're all the same family. So I don't see, it's not like a pedo practice where you have multiple people in an open area. So as far as the toys and the things in the sensory room are concerned, yeah, we're gonna, that's gonna be a little bit more of a challenge because whether it's, the patient or someone playing with it, we're probably going to have to take away a lot of the smaller things, definitely take away anything that they would be happy to put in their mouths, and things that we can either wash well or sterilize with cavi wipes.
Okay, very good. The next thing is also regarding kind of an informed consent. Do you have informed consent for forms of stabilization? And then also a specific question, where do you get the Velcro stabilizers?
Yes, yes, on the informed consent. So for any form of stabilization, and so I don't care if I'm using the arm stabilizers, a pillowcase, a mouth prop, I always get them to sign that, understanding that we're going to use the least amount of stabilization required to do what we need to do. But yes, and for what I do, the documentation is I have that form, and then in my notes we basically say, parent gave verbal consent again. Parents or caregivers are always in the operatory with me anytime that we're using any form of stabilization. Just like I said, there's too many opportunities for people to, I guess, trap you, put in a lawsuit or whatever. So I just avoid all of those opportunities. Where do you get those arm stabilizers? It's special care dentistry. It's what I can do, Steve, is I can actually put that on. I'll give that to you, and we can put that up when this comes up.
Okay, very good. There was one question that came in many times through this. People loved the videos that you shared, and they were asking for links to those videos. I'll go ahead and address that if it's okay with you, Dr. Dent. When we post this on our elevateoralcare.com/elevatingcare website, we will also post those videos so that you can use them if that's okay with you, Dr. Dent.
Yes, that's fine.
Okay, very good. Okay. Let's see if we've got any more questions here that we have not yet answered. This is regarding fluoride varnish and prophies. Why aren't you using a fluoride varnish? Why would you just do a toothbrush with paste and polish, since pumice polish is shown not to be a benefit for tooth structure? Are there specific reasons for that?
No. So please understand, everybody in my practice gets a fluoride varnish. I didn't put that in obviously I can't put that in the kits for the brush and bite kits, but everybody in my office gets a fluoride varnish. So yes, I agree with whoever asked that question. Brushing and flossing doesn't do much other than clean. It's not great for caries prevention, but we use a varnish. We do not use a foam or trace, really just out of compliance.
Okay, very good. And I think this was the last question we have. Since we are mandated reporters of child abuse, elder abuse, how do you tell the difference between when a patient shows with injuries, whether it's due to self-injurious behavior or abuse?
Usually because they are still doing the same behavior in your practice. Like I said, if concern, it's a lot easier to, I guess the knee jerk is, man, that the child or adult's getting abused, versus when they come into your office, they're physically hitting themselves, beating their head against the wall. I've had that before. I've had a patient come in with a football helmet and boxing gloves on. It was whatever they could do to help prevent them from hurting themselves. So, you got to make your own decisions and make your own call on that. But if you do your due diligence and just watch how the caregiver or parent is interacting with them, get some. I have no problem asking where the injuries came from. Definitely document it. Take an intraoral picture of the patient so you can see. I mean, if it's something that is consistent, you may want to check, but a lot of them, like I'll give you an example. I have a lot of patients that bite themselves. So they have cuts, bruises, calluses everywhere on their arms. And if you didn't work in this field a lot, it looked like someone was beating them. But they also sit in my chair and bite the same spots. So like I said, it's just one of those you can determine just if the patient's doing it themselves. Steve, to go back to that question, it's about where to find the arm stabilizers and the bot blocks. It's specializedcare.com. So specializedcare.com, and you can order that for yourself online.
Okay, very good. Appreciate that. We'll do one last question here. What is your preference of replacement when a special needs patient hasn't learned to tolerate prophy paste texture?
So how do I desensitize it at home? Is I get a parent to mix their toothpaste with about 1/4 of a teaspoon of baking, so it increases the grit. And then what we'll do is like I said, it does turn into a little bit of a desensitization process. But if you can start increasing the grit, flavor's easy, because we all have. They make non-flavored prophy paste, so it's really the grit. And a lot of times they may only like to use a specific toothpaste. Specific flavor that doesn't come in something that we can get here in the office. So I tell them to bring their toothpaste from home, and I mix it with a little of the non-flavored prophy paste.
Okay, appreciate that. Well, again, thank you very much for a great presentation. There were numerous comments and thank yous that came in saying this was a fantastic presentation, so we very much appreciate that. Kevin, I'm going to hand it back to you for the closing statements.
Thanks, Steve. Thank you, Dr. Dent, for a great presentation, and thanks to everybody for joining. In the For What It's Worth category, our sister Kay loved to travel. Had we met while Kay was thriving and alive, you would have been her dentist, and whatever you told me was the fee to pay, I would have paid. So, so for what it's worth to the other caregivers out there, we as a company encourage all offices to open up to special needs patients. To our guests, remember your CE certificates will be emailed to all attendees in about 2 hours. Don't forget to check your spam folder. Be sure to follow us on Facebook and Instagram for links for new webinars. The link you see on screen right now gives you access to our archived webinars, including Dr. Dent's today. As soon as we can prep and get it loaded onto the site with this quiz-based CE, it'll be there. That should occur sometime in the next week. If you need any help with access to these or any of the other CE courses that we have, just give us a call at 877-866-9113. So you'll see that number down at the bottom of the screen. Anybody that answers that phone would be happy to help. On our website, you'll also find a button, elevateoralcare.com, to request an informative staff meeting for your office. Education on the latest oral health prevention, that's what we do as a company. And we frankly can't wait to get back to do what we do best, helping you serve your patients. So everybody, thanks and have a safe and wonderful day. Thank you, Dr. Dent.
Thank you.